Hi doctors, I am Dr. Sesha and today I will be reading along with you Oxford Handbook of General Practice, page number 160 onwards. Uh, this is as a part of my preparation for the MRCGP International AKT exam. So let me start. Management of alcohol misuse. Assessing for alcohol misuse. Screening. Ask the patients directly about their alcohol use. Use standardized questionnaires to identify the patients with harmful and hazardous patterns of alcohol consumption. Example, the audit questionnaire. Suspicious signs and symptoms. Increased or uncontrolled BP, obesity, recurrent injuries, accidents, non-specific GI complaints, back pain, poor sleep, tiredness. These are all suspicious signs and symptoms of alcohol abuse. Risk factors for abuse: previous personal history of misuse, family history of alcohol misuse, poor social support, work absenteeism, emotional or family problems, financial and legal problems, drug problems, alcohol associated with work. He's a publican. So, examination. There is smell of alcohol, tremor, sweating, slurring of speech, increased blood pressure, and signs of liver damage. Investigations. What investigations would you advise? First is FBC, because there will be an increase in mean corpuscular volume. LFTs, increase in GGT in 25% of heavy drinkers, increase in AST more than ALT in alcohol-induced liver injury, increase in bilirubin. Ultrasound scan, fatty liver or cirrhosis, often incidental findings. Alcohol and driving. Advise patients who persistently misuse alcohol that they must stop driving and notify the DVLA. License is revoked until 6 months of abstinence or controlled drinking. That is more than 1 year if group 2 license, and normalization of blood parameters. So, alcohol management strategies for patients drinking within acceptable limits. And what are the acceptable limits? Is 14 units per day. 14 units per week. Reaffirm the limits. So, people who say, no, I'm drinking very little alcohol or within the 14 units limit, you should tell them that 14 units is the limit. And if you are drinking or going to drink beyond that, it is called misuse. If misusing alcohol, if they are a non-dependent drinker, means they don't have any withdrawal symptoms when they are stopping the drinking. So brief GP intervention decreases the drinking in 24% of patients. Present results of screening interventions like audit and identify the risk. Provide information about safe amount of alcohol and harmful effects of exceeding these limits. Assess whether the patient is receptive to change. If so, agree targets to decrease consumption, encourage and negotiate a follow-up. So if there patient is an alcohol dependent drinker who suffers withdrawal symptoms if they decrease alcohol consumption, like anxiety, fits, delirium tremens. If wanting to stop drinking, refer him to the community alcohol team. Suggest self-help organizations, example, Alcoholics Anonymous, involve his friends or families. If he is wanting to stop drinking, detoxification in the community usually uses a reducing regimen of chlordiazepoxide over a period of 1 week. So, you have to give chlordiazepoxide in the community, not in the hospital, for a period of 1 week. Various regimens are used. Example, 20 to 30 milligrams QDS on days 1 and 2, then 15 milligrams QDS on days 3 and 4, 10 milligrams QDS on day 5, 10 milligrams BD on day 6, 10 milligrams OD on day 7, and then you need to stop. If ambivalent or unwilling to change, provide information. Reassess and re-inform on each subsequent meeting. Support the family. Vitamin supplements. People with chronic alcohol dependence are frequently deficient in vitamins, especially thiamine. Give oral thiamine indefinitely. If severe, 200-300 micrograms per day. If mild, 10 to 25 milligrams per day. It's also milligrams, 200 to 300 milligrams per day. And if it is mild, then 10 to 25 milligrams per day. During detoxification in the community, give thiamine 200 milligrams OD for 5 to 7 days. along with chloride epoxide. So relapse. Relapse is common. Warn the patients, encourage to reattend. Be supportive. Maintain contact or decrease the frequency and severity of relapses. Uh, Consider the drugs to prevent relapse, example acamprosate and disulfiram. Specialist initiation. Delirium tremens. We will read about delirium tremens when we go to page 1103. So by management of alcohol misuse, this is a flow chart. Assess the amount of alcohol a patient is drinking on a regular basis when they are seen in the surgery for any reason, and ask for patients presenting with symptoms and signs which could be associated with excessive alcohol consumption about the amount of alcohol they drink. So if they are drinking within the acceptable limits, that is less than 14 units per week, reaffirm safe drinking limits. If they are drinking excessively more than 14 units per week, see if they are willing to change. Yes and no. So if they are willing to change and the answer is no, then record what is the amount of record the advice given to decrease alcohol, give the patient advice leaflet, record advice to cut down whenever the patient is seen in the surgery. Willing to change, yes. Dependent drinker, provide advice, refer to the community alcohol team and consider detoxification. He is dependent drinker. So you need to give chlordiazepoxide also. And non-dependent drinker, you provide advice, suggest the patients to keep a diary of alcohol consumption and agree targets and follow-up. Alcohol management strategy. Community detoxification is contraindicated for patients with poor home environment, poor cooperation, previous failed detoxification at home, history of previously complicated withdrawal, example withdrawal of seizures or delirium tremens, withdrawal seizures or delirium tremens, increased risk of suicide, uncontrollable withdrawal symptoms, confusion or hallucinations, epilepsy or fits, malnourishment, severe vomiting or diarrhea, acute physical or psychiatric illness, and multiple substance misuse. So in all these patients, you cannot detoxify in the community. You have to see for institutional detoxification. For further information, you can go to all these websites and study. Assessment of drug misuse. 14% of males and 8% of females aged 16 to 59 report taking illicit drugs in the past year. A majority of patients on treatment programs report opioid misuse. Heroin 54% and methadone 13%. But most frequently abused drugs are cannabis, amphetamine, ecstasy, and cocaine. So these are the most frequently misused drugs: cannabis, amphetamine, ecstasy, and cocaine. Three factors appear important: availability of the drugs, vulnerable personality, and social pressures, particularly from the peers. Commonly misused drugs are also depicted in table 7.5, page number 164. We will read as and when we reach that page. Controlled drugs regulations, page number 124. We will read that. Legal highs. New psychoactive substances or NPS, legal highs, illegal highs, or illegal highs are substances designed to produce similar effects of controlled drugs like cannabis, cocaine, and ecstasy, but structurally different enough to avoid being subject to Misuse of Drugs Act. The UK Psychoactive Substances Act 2016 bans manufacture, import or export or supply of NPS, but possession of NPS is not an offence. So that is the glitch in the Act. Detection. Warning signs suggest drug misuse. Suggesting drug misuse. Use of services. Suspicious request for drug of abuse. Example, no clear medical indication. Prescription requests are too frequent. Signs and symptoms. Inappropriate behavior. Lack of self-care. Unexplained nasal discharge. Unusually constricted or dilated pupils. Evidence of injecting, example, marked veins. Hepatitis B, C, or HIV infection. Social factors. Family disruption or criminal history. Assessment. Assess on more than one occasion before deciding how to proceed. Exemptions are severe withdrawal symptoms or evidence of an established or requiring regimen or requiring continuation. Points to cover. General information. So whenever you assess, you need to cover take general information, check the identification, ask for an official document, contact with other agencies including the last GP, check accuracy. Current residence, family and partner and children, employment finances, legal problems or criminal behavior, past and present. So whenever they are asking for coming for you to your practice to asking you to prescribe a particular drug and you think it is a drug misuse or abuse, then you have to make assessment about the general information, history of drug use or risk-taking behavior, reason for consulting now. So you have to find out from the patient what is the reason for consulting now and willingness to change, current and past usage, unsafe sexual practices, knowledge of risks, medical and psychiatric history, complications of drug abuse like HIV, hepatitis, accidents, general medical and psychiatric history on and examination, alcohol abuse, overdose or accidental, either accidental or deliberate. Investigations. Consider urine toxicology to confirm the drug misuse. Consider blood for FBC, full blood count, LFTs, hepatitis B and C, HIV serology with consent and counseling. And another test according to medical history and examination. Specific drugs. See Table 7.5 P164. Gabapentin and pregabalin are increasingly being used as drugs of abuse, particularly in prisons. Preventing the prescription drug dependence. Benzodiazepine and jet class drugs. Opioids 167 page. Prescribing for drug misusers. Approach with a special caution. Some controlled drugs can be dispensed to substance misusers in installments, providing they are prescribed on special NHS prescription forms FP10 MDA England, WP10 MDA Wales, and GP10 Scotland, HS21 Northern Ireland. The prescription specifies the number of installments, the intervals between the installments, and if necessary, instructions for supply at weekends or bank holidays, total quantity of controlled drug providing treatment for a period of less than 14 days, and total quantity to be supplied per installment. As the general principle, substitute opioid medicines are prescribed in daily installments. The prescription must be dispensed in the date on which it is due. Other equipment for drug misusers. Doctors, pharmacists, and other drug workers may provide supplies of alcohol swabs, sterile water, 10 ampules of less than 10 ampules of 2 ml or less, mixing utensils, filters, citric acid to misusers for the purpose of harm reduction. Notification of drug misusers. Patients who start treatment for drug misuse in the UK in specialized drug treatment centers have their details passed anonymously to National Drug Monitoring Services. All types of problem drug misuse are reported. Databases cannot be used as a check on multiple prescribing as data are anonymized. Driving and drug misuse. Page 99. Overdose. Page 1098. Traveling abroad with controlled drugs. Page 125. So this is table 7.5. It is commonly misused substances in the UK. There are so many substances everyone needs to study on their own about the details of these substances because it's very extensive. Heroin, cocaine, crack, ecstasy, LSD, magic mushrooms, barbiturates, amphetamines, cannabis, tranquilizers, anabolic steroids, poppers, and solvents. Management of drug misuse. Management aims to help the patient stay healthy until a drug-free life is achieved, in particular by decreasing the risk of infectious diseases, drug-related deaths, and criminal activity to finance drug habits. Care can be difficult due to chaotic lifestyle and drug-seeking behavior. Set rules of engagement. GPs interested in working in specialist drug misuse treatment centers or providing substitute prescribing in the community should obtain specialist training. The RCGP Substance Misuse Unit provides certificate courses in management of drug and alcohol misuse. Role of the GP. Important role in identifying drug misuse, including prescription drugs, and as assessing willingness to modify drug behavior. GPs can also provide information and advice as appropriate about safe injecting, overdose prevention, specific risk of the drugs, including local risk, contaminated street drugs, safe sexual practices, driving and drug misuse, other sources of support and information. Medical care. Routine medical care including treatment of complications of drug misuse, that is infected injection sites, routine preventive care like cervical screening and contraception, blood-borne viruses, hepatitis B, C, HIV testing as needed, hepatitis B vaccination to re-injecting drug misusers not already infected or immune, and close contacts of those infected, use an accelerated regimen of immunization at 0, 7 and 21 days and a booster after 12 months. So this is a completely different regimen for immunization in drug abusers where you give a hepatitis B vaccination at 0, 7 and 21 days, an accelerated vaccination regimen and a booster after 12 months. So this is a cycle of dependence or abuse. Pre-contemplation. Patient is unaware that there is a problem. So it's a pre-contemplation state. Patient doesn't know that there is a problem. Then there comes the contemplation phase. Ambivalence might acknowledge a problem and need for change. Then comes the decision. Hypothetical point at which a decision is made whether to change or not. Action. Patient seeks help. Then maintenance. Needs to consolidate gains to avoid a relapse. Relapse can occur at any stage, not a failure but a learning experience to improve chances the next time around. And then after the relapse, again there is a phase of pre-contemplation and again contemplation, decision making and action. This is the stages of change in addiction. Pre-contemplation, contemplation, decision, action, maintenance, relapse, again pre-contemplation. Referral for specialist assessment for treatment of drug misuse. Patients requiring substitute prescribing, example with methadone or buprenorphine for heroin misuse, should be referred for specialist treatment center. Prescription of benzodiazepine addiction 169. Prescription opioid misuse. Suspect if taking long-term opioid medication for any non-cancer condition, particularly drug-seeking behavior. Example, early request for replacement medication, refusal to see a GP for reviews, or reluctance or refusal to decrease the dose of opioids. Action. Discuss your concerns with the patient directly. Offer patients with option of referral to a specialist drug treatment center or for substitute prescribing with methadone or buprenorphine or detoxification. Detoxification. Convert patients on patches to long-acting oral medication. Agree a gradually reducing dose of opioid, example 10 to 25% of the dose monthly. Patient who detoxify should be warned of the risk of overdose if they relapse and restart opioids again at the same dose. Monitor frequently. Opioid withdrawal symptoms. Within 24 hours, the patient will develop muscle aches, restlessness, anxiety, watering from the eyes, runny nose, excessive sweating, yawning, inability to sleep. Later, he develops opioid will cause constipation. So, in opioid withdrawal, the patient will develop diarrhea, abdominal cramps, goosebumps like a cold turkey, and nausea, vomiting, blurred vision, dilated pupils, tachycardia, and increased PP. One important thing which we can remember is dilated pupils is seen in opioid withdrawal, whereas in opioid poisoning it is pinpoint pupils. Safe injecting advice. Provide information about safer routes of drug administration. Example, smoking or rectal administration for heroin abusers. So these are rather than injecting IV or IV, smoking and rectal administration are more safer. So we need to Advise them safe injecting advice. Discourage IM or subcutaneous administrations. Advise safe injecting. Never inject alone. Always inject with the blood flow. Rotate sites. Avoid the neck, the groin, the penis, the axilla, the foot, and the hand veins. And if any infected areas or swollen limbs. Poor veins indicate poor technique. Find out what the patient is doing. Drugs or equipment. Sterile injecting equipment with small bore needle. Sterilize the injecting equipment with a small bore needle. Dispose the equipment safely after use. Avoid unsuitable preparations, example crushed tablets or drug cocktails. First aid. Learn the basic principles of first aid or CPR. Encourage calling for an ambulance. Suggest an naloxone kit for opioid overdose. Available from the drug treatment centers. Decreases the death from opioid overdose. That's a naloxone is an antidote for opioid overdose. Opioid overdose risk factors. What is the risk factors? Injecting heroin, longer injecting career, depression and suicidal thoughts, lower tolerance to detoxification or imprisonment, multiple drug use, particularly CNS depressants, sharing equipment or other high risk injecting behavior may indicate lower concern about personal risks. Not being on a premature exit, not being on or premature exit from a methadone treatment program. Recent non-fatal overdose, high levels of use or intoxication, high levels of alcohol use. So these are all the risk factors for overdose. Insomnia. From the Latin meaning no sleep, describes the perception of disturbed or inadequate sleep, that is 1 in 4 of UK population, males more than females, are thought to suffer from varying degrees. Prevalence increases with age, rising to 1 in 2 amongst over 65s. Causes. Numerous common examples include minor causes, self-limiting causes like travel, stress, shift of work, small children, arousal. Psychological causes, one half have mental health problems, depression, anxiety, mania, grief or alcoholism. Physical causes, drugs like steroids. Steroids cause insomnia, pain, pruritus, tinnitus, sweats, example menopause, nocturia, asthma, obstructive sleep apnea. These are the physical causes of insomnia. Definition of a good night's sleep. How do you define a good night's sleep? Less than 30 minutes to fall asleep. Maintenance of sleep for 6 to 8 hours. Less than 3 brief awakenings a night. Feels well rested and refreshed on awakening. Management of insomnia. Careful evaluation. Many do not have sleep problem themselves, but a relative feels there's a problem. That is, the retired milkman continues to wake up at 4 a.m. Others have unrealistic expectations about sleep. Example, they need 12 hours per day. Reassurance alone may be that all that is needed. For genuine problems with insomnia, eliminate physical problems preventing sleep. Example, treat asthma or eczema. Give long-acting painkillers to last the whole night. Consider HRT or clonidine for sweats. Refer if obstructive sleep apnea is suspected. Treat the psychiatric problems like depression or anxiety. Sleep hygiene. Box number 7.2. Relaxation techniques. Listen to a podcast, a relaxation class often offered by local recreation centers or adult education centers. Many physiotherapists can also teach relaxation techniques. Consider the drug treatment only as a last resort. Benzodiazepine should be prescribed for insomnia only when it is severe, disabling, or subjecting the individuals to extreme stress. Only prescribe a few weeks supply at a time due to potential for dose dependence and abuse. Never put benzodiazepines or jet drugs on repeat prescription for sleeping problems. Beware the temporary resident who has forgotten his or her night sedation. Drug treatment. Benzodiazepines like temazepam, zolpidem, zopiclone, and low-dose TCA amitriptyline 10 to 75 milligrams, Noctare are commonly prescribed for patients with insomnia. Side effects include amnesia and daytime somnolence. Most hypnotics do affect daytime performance and may cause falls in the elderly. Warn patients about the effect on driving and operating machinery. Box number 7.2, Principles of Sleep Hygiene. Do not go to bed until you feel sleepy. Do not stay in bed if you are not asleep. Avoid daytime naps. Establish a regular bedtime routine. Reserve a room for sleep only if possible. Do not eat, read, work, or watch TV in it. Make sure the bedroom and bed are comfortable and avoid extremes of noise and temperature. Avoid caffeine, alcohol, and nicotine. Have a warm bath or a warm milk drink at bedtime. Take regular exercise but avoid late night hard exercise. Sex is okay. Monitor your sleep with sleep diary. Record both the times you sleep and its quality. Rise at the same time every morning regardless of how long you have slept. What are the complications of insomnia? Reduced quality of life, reduced concentration, memory, may affect the performance of daytime tasks. Relationship problems. Risk of accidents. 10% of motor accidents are related to tiredness. Other causes of insomnia: obstructive sleep apnea, sleepwalking, night terrors, restless legs. We will read them as and when we reach that page numbers. Addiction to prescription benzodiazepines and Z drugs. Common in primary care. Regular use of hypnotics for insomnia rapidly leads to tolerance in less than a month. Long-term use results in decline in cognitive function and blunting of emotions. In older people, hypnotic use is also associated with increased falls and associated injuries. However, stopping the drugs results in rebound insomnia and other effects which may be severe, including anxiety, panic attacks, muscle pain, and rarely seizures. Stopping hypnotics. Discuss stopping hypnotics with any patient who has regular prescriptions for more than 3 months. Explain long-term risk of taking these drugs. Switch to an equivalent dose of diazepam. So you were giving them temazepam and then zopiclone, zolpidem and amitriptyline. So whatever you are giving, you give them, switch them to an equivalent dose of diazepam and agree a schedule for reduction. Usually 1 milligram of diazepam every 2 weeks you reduce, although can be slower if necessary. Withdrawal symptoms tend to occur 2 to 10 days after reduction in dose. Dose equivalence. 5 milligram diazepam is approximately equivalent to 10 milligrams temazepam, 5 milligrams nitrazepam, 500 micrograms of lorazepam, 50 milligrams of chlordiazepoxide, 50 milligrams of oxazepam, 7.5 milligrams zopiclone, or 10 milligrams of zolpidem. So we need to remember this dose equivalence. So we are done with the 10 pages and the chapter 7. So next we will read chapter 8. Chronic disease and elderly care. Page number 171. Chronic disease management. The predominant disease pattern in the developed world is one of chronic or long-term illness. In the UK, 41% of the adults, males, and 43% of adult females report long-term illness. This figure is increasing in our population as our population is aging. People with long-term conditions are very intensive users of services. They account 52% of GP appointments, 65% of outpatient appointments, and 77% of hospital bed days. Long-term conditions frequently managed in GP practice are back pain, cancer, diabetes, dementia, chronic neurological conditions like Parkinson's disease and multiple sclerosis, psychiatric illness, example depression and psychosis, HIV, arthritis of all types, chronic lung diseases, cardiovascular diseases, example BP, heart disease, stroke, renal or liver failure, irritable bowel syndrome and inflammatory bowel disease. Although details of chronic illnesses management depend on the illness, people with chronic diseases of all types have much in common with each other. They all have similar concerns or problems and must not deal with only their diseases but its impact on their lives and emotions. Common patient concerns who have chronic disease. Finding and using health services. Finding and using other community resources. Knowing how to recognize or respond to changes in chronic disease. Dealing with problems and emergencies. Making decisions about when to seek medical help. Using medicines and treatments effectively. Knowing how to manage stress, depression that goes along with chronic illness. Coping with fatigue, pain, and sleep problems. Getting through exercise, enough exercise. Maintaining good nutrition. Working with your doctors and other care providers. Talking about your illness with family and friends. Managing work, family, and social activities. So these are the common concerns. Whether the patient has a heart problem or a BP problem or a diabetes, he has all these concerns and he has a stress related to these concerns. But if they don't, he or she doesn't have answer to these concerns. Common elements of effective chronic illness management. Involvement of the whole family. Chronic diseases do not only affect the patient but everyone in the family. Collaboration between the service providers or patients and the carers. Negotiate and agree a definition of the problem. Agree the targets and goals for management and develop an individualized self-management plan. Personalized written care of plan. Take into account the patient and carer's view and experience and the current evidence base. Tailored education in self-management. Patient with diabetes spends 3 hours per year with a health professional. The other 8587 hours he or she manages his or her own condition. Helping the patient with chronic disease understand and take responsibility of their conditions is vital. Planned follow-up. Proactive follow-up according to the care plan. Use the disease registers and call and recall systems is important. Monitoring of outcome and adherence to treatment. Use of disease or treatment markers. Monitoring for concordance. Example, checking prescription frequency, medicine management programs, etc. Tools and protocols for stepped care. Provide a framework for using limited resources to the greatest effect. Step professional care in intensity. Start with limited professional input, systematic monitoring, and then augment care for patients not achieving an acceptable outcome. Targeted use of specialist services. For those patients who cannot be managed in primary care alone, you need to advise them to go for specialist services. Monitoring of process. Continually monitor management through clinical governance mechanisms. Multimorbidity. Page 174. Depression and chronic disease. Depression is common among people who with a chronic disease. It is reported to affect 30 to 50% of those with epilepsy, CVD, dementia, cancer, and type 2 diabetes and arthritis. Interaction between depression and chronic physical illness. Those with chronic medical illness adversely affects the prognosis. Conversely, treatment of depression can improve the prognosis. Interaction between depression and chronic physical illness. Depression in those with chronic medical illness adversely affects its prognosis. Conversely, treatment of depression can improve the prognosis. Depression is associated with increased mortality, morbidity, disability, and poorer quality of life, increased prevalence of smoking and sedentary lifestyles, poorer chronic disease outcomes like higher HbA1c, increased use of services and increased healthcare costs, poor concordance with medication and management plans. Detection of depression. Use NICE depression screening questionnaire. During the last month, have you often been bothered by feeling down, depressed, or hopeless? That is the first question. During the last month, have you often been feel bothered by having little interest or pleasure in doing things? That is the second question. These are the first two questions. Either you are feeling down, depressed, or hopeless, or you don't have any interest or pleasure in doing things. These two questions, the positive response to any of these question should prompt further assessment within the following 3 questions. So if there's a positive response to these 2 questions, then you have to ask the next 3 questions. During the last month, have you been bothered by feeling of worthlessness, poor concentration, or thoughts of death? So these are the rest of the 3 questions. For detection of depression using the NICE depression screening questions. These are the NICE depression screening questions. There are 5. Residential care homes. 2,20,000 people in residential care in England. 77% are elderly with long-term health conditions. Of younger residents, 61% have learning disabilities, 21% have mental illness, 17% have physical disability, and 2% have substance misuse problems. Chronic disease. Chronic disease management for residents of care homes is frequently neglected. Ensure that the chronic disease management checks takes place, including routine blood check monitoring, physical health checks, and medication review. Deprivation of liberty safeguards (DOLS) is in page 1106. We will read it there. Multimorbidity. Definition and statistics. Multimorbidity refers to the presence of more than 2 long-term health conditions in a single individual. It is common. 1 in 6 patients in the UK have more than one QOF condition. 65% of people more than 65 years and 82% more than 85 years have 2 conditions, males more than females. However, although prevalence of multimorbidity increases with age, multimorbidity can affect all age groups. It is more common in socially deprived populations and complexity tends to increase with more conditions the patient has. Challenges of multimorbidity. Single disease guidelines. Since the early 1990s, a plethora of guidelines have been produced synthesizing research around a single disease entities into best practice that we have learned to follow rigidly. However, most research is carried out on populations without comorbidities, so it may not be applicable to patients with multimorbidity. Rigid adherence to guidelines for patients with multimorbidity can lead to polypharmacy with subsequent adverse effects and conflicting treatment targets or advice. Condition overlaps. Some conditions have similar symptoms and signs, resulting in diagnostic overlap. For example, breathlessness may be due to heart failure or COPD. One condition may also have an impact on other. For example, chronic pain can result in worsening of depression. This makes unraveling a patient's medical problem very difficult. Polypharmacy. It is easy to keep adding medication as new guidelines are released to reach performance targets or as patients present with symptoms. It is much harder to stop a medication. The more medications a patient is taking, the greater the risk of interactions between the medications and the adverse effects. Medical complexity. In a traditional GP appointment, the GP works alone and has 10 minutes to assess the patient and formulate a management plan. That is simply not enough time for highly complex patients with multiple interacting and interdependent problems requiring a holistic multidisciplinary approach. Time pressure can result in inadequate assessment or disengagement of the patient or the carers. High use of services. Patients with multimorbidity use more GP appointments, take more medication, and have more outpatient appointments, and are likely to be admitted to the hospital both for routine and emergency reasons. Disorganizing or fragmentation of care. The medical model of care uses a systems-based approach. Early specialization of doctors has resulted in silo working. Patients with multimorbidity are frequently under review by several different specialist medical teams, resulting in mixed messages and prioritization of some of the problems over the others, regardless of whether these are the priorities of the patient. Even in primary care, it is common for the patient with multimorbidity to be asked to attend multiple chronic disease reviews in the same practice. Patient burden. Multimorbidity is a huge burden for the patient and the carers. They have to attend multiple appointments and manage complicated drug regimens as well as dealing with the effects of their illness and the side effects of the treatment. Multimorbidity is associated with poorer quality of life and increased risk of anxiety and depression. So, we have to identify the patient at risk of adverse events. Not all patients with more than two conditions need additional support. As multimorbidity is common, it is important to focus resources on those who are most risk of adverse events. Consider patients at high risk of unplanned care or home admission. Computer algorithms aid identification, electronic frailty index, QA admissions predicting emergency over QA admissions, predicting emergency admissions over the next year, PENOI. These are the computer algorithms which aid in identification of high risk unplanned care home admissions. Number of regular prescribed medications. In general, the patients taking more than 15 regular prescribed medicines are at high risk. Those taking 10 to 14 medications are at moderate risk. Frailty. Assesses using Assess frailty using gait speed more than 5 seconds to walk 4 meters. Self-reported health status on a scale of 0 to 10, less than 6 suggests frailty, or formally validated tools like Prisma 7 questionnaire. A score of more than 3 or 3 suggests increased risk of frailty and a need for further review. Holistic approach to management of multimorbidity. For patients at high risk of adverse events, consider longer review appointments and try to ensure continuity. Example, with a named GP. Coordinate care in the practice. Example, routine blood tests all done at the same time. All routine chronic diseases reviews during the same appointment. Quantities of repeat medicines and review dates aligned. List of conditions and problems from patient's care or carer's perspective. Explore how the patient's health conditions and treatments interact and how this affects the quality of life. Discuss the patient goals, health priorities, and treatment preferences. This may also include advanced care planning decisions. Discuss the benefits and risks of following recommendations from guidance on single health conditions. Review medications or treatments weighing the risk-benefit of each with the patient. Explore ways to increase the quality of life by decreasing the treatment burden, adverse events, and unplanned care. Focus on solving the problems and symptoms control. Be alert for depression, considering screening. Consider the screening for depression. Create a care plan and share this across the multidisciplinary team, highlighting the person responsible for coordination of care. Ensure that the patient and the carers understand the plan and know what to do if anything changes and in emergency situations. Review the patient and care plan regularly. Genetics and genomics. There are 46 chromosomes, 22 matching pairs with matching genes, autosomes, and one pair of sex chromosomes which will match XX for females or XY for males. Genetics refers to the study of individual genes. Genomics refers to a person's entire genetic code or the genome. There are many ways in which variations in a genetic makeup result in disease. Changes in chromosome number. Alteration in number of chromosomes, example in Down syndrome, and there is an extra 21 chromosome 21. Sex chromosomes abnormalities. A sex chromosome is duplicated or deleted. Turner syndrome is XO. Klinefelter syndrome is XXY or XXYY. Gross structural changes in the chromosomes. Either there is a translocation, part of one chromosome is transposed or translocated to another. If no genetic information is lost, there is no clinical effect. That is called a balanced translocation, although offsprings often have problems. 6% of children with Down syndrome have a translocation. Deletion. Loss of portion of the chromosome. Example in Cry-du-Chat syndrome, deletion of the short arm of chromosome 5. Single gene abnormalities. Autosomal dominant inheritance. More than 1,000 diseases are recognized, all individually rare. Heterozygotes have the disease. 1 in 2 pregnancies of an affected individual are affected. Usually, males are equal to females. Expression of the gene may vary. Example, tuberous sclerosis, Marfan syndrome, myotonic dystrophy, neurofibromatosis. Occasionally, genes may be co-dominant and both the genes inherited from the mother and the genes inherited from the father are expressed simultaneously, like blood types. So mostly autosomal dominant disorders are structural deformities. See, Marfan's is a structural problem, myotonic dystrophy is a structural problem, neurofibromatosis is also structural, tuberous sclerosis is also structural. Whereas when we compare to autosomal recessive inheritance, more than 700 diseases that only manifest in the homozygote. Heterozygotes may be asymptomatic or have milder abnormalities. To develop severe disease, the affected gene must be inherited from both the patient's parents. The risk of an affected pregnancy is 1 in 4. Usually, males are equal to females. The affected individuals have unaffected children unless their partner is a heterozygote. Example like in sickle cell disease, thalassemia, and cystic fibrosis. So in autosomal recessive inheritance, you have mostly metabolic abnormalities and second, you have carriers. But in autosomal dominant, you don't have carriers. Anyone who has a gene will have the disease. Sex-linked disorders. Around 100 are recognized. Most of them are recessively inherited from the mother and affect only the male offspring. Male child of a heterozygote mother has 1 in 2 chance of developing the disease. Female child has 1 in 2 chance of being a carrier. Examples are Fragile X syndrome, hemophilia, red-green color blindness, Duchenne muscular dystrophy. So examples of sex-linked recessive disorders are Fragile X, hemophilia, red-green color blindness, Duchenne muscular dystrophy, even though it is a structural problem, but it is sex-linked recessive, and mostly females are carriers and males are affected. Mitochondrial disorders. There are many thousands of mitochondria in each cell. Mitochondria have their own DNA, empty DNA, and mitochondrial conditions affect males and females equally. They result from mutation in the empty DNA which can be inherited from affected females only. So, if a female is affected, she can only transmit the illness to the generations. So, are always passed through female family line. Example, Leber's optic atrophy. Because only the female passes on the mitochondria to the offsprings, but as the sperm doesn't have mitochondria. Genetics and genomics. This is the autosomal dominant inheritance. So if 50% chance of affecting the children, autosomal recessive, only 25% chance, and then 50% are carriers, 25% is unaffected. This one is sex-linked recessive inheritance. New mutations. Not all who present with a genetic condition have a family history. Often a new genetic mutation will arise when the egg or sperm is formed or at the embryonic stage. Polygenic inheritance. All diseases result from combination of genetic and environmental factors. Variations in different parts of individual's genome might increase or decrease the chance of developing many common diseases like cancer, diabetes, and heart disease. These are polygenic inheritance. When you speak of diabetes in the family or heart disease in the family, but you don't say that any particular gene is involved because it is polygenic, including genetic as well as environmental factors. Cancer genes or oncogenes. Alteration in the genetic makeup of the cancer cells usually control cell division or multiplication. It is not inherited. Identification of faulty tumor genes can potentially facilitate choice of cancer treatment and improve effectiveness and prognosis. Personalized medicine. This is a move away from the one-size-fits-all approach to management of a disease. Recent advances in genomic medicine, both in terms of testing and mapping of human genome, now enable us to integrate information from individual genomic code together with the patient's history to help us better identify those at a risk of disease and target management options to improve treatment outcomes. So here we are at page number 178. We will stop here for today's discussion, and the next we will start from page number 178 with the topic medically unexplained symptoms. Thank you all. Good day.